so I think we'll get started. My name's Claire Healy. I'm one of the genetic counseling managers in the Smilow Cancer Genetics and Prevention Program. So on behalf of the program, I'll welcome you all to night 2 of our seminar series. The title of tonight's seminar is Implementing Screening and Prevention Strategies for Individuals Identified to be at High Risk for Cancer. A few housekeeping things before we get started. Please try and keep yourselves muted and remain muted during all of the talks. We've saved time at the end of all of our lectures for questions, but feel free as we go through these lectures to enter questions into the Q&A. And tonight we're going to start with our first speaker, Dr. Melanie Lynch. Dr. Lynch is Director of Breast Surgery at the Smilow Cancer Hospital locations in Bridgeport, Fairfield, and Trumbull, and the Norma Freem Breast Center. She's a board-certified general surgeon and fellowship-trained surgical oncologist. And Dr. Lynch, thank you for joining us.
Thank you. Thank you for the kind introduction and for letting me join tonight. I'm going to share my screen. How's that look? Oh. There we go. How's that look? Good?
Perfect.
Okay. So when we start a discussion of breast cancer risk, we certainly have to talk about breast cancer incidence, and looking at breast cancer incidence and how this has changed over the years. You can see how with increasing screening mammography, our breast cancer incidence did go up. Our mortality, though, has continued to go down, and that's because most of the cancers that we're identifying are in the earlier stages when they are curable. You'll notice in this timeline, you see this peak here in the 1980s. This is when screening went up dramatically when our first lady was diagnosed with breast cancer. The other thing you're going to notice here is this dramatic drop off in breast cancer incidence that happened in the early 2000s with the publication of the Women's Health Initiative trial that demonstrated a link between hormone replacement therapy at the time of menopause and breast cancer risk. When we think about what affects breast cancer risk, we know that there are a number of factors that we can control, and there are a number of factors that are out of our control. We know that we can decrease risk by maintaining a healthy weight, by exercising regularly, and by limiting the amount of alcohol that we drink per week. We also know that there's some things that we can't control, including exposure to ionizing radiation for treatment for a cancer, especially at a young age, a family history of cancer, or an inherited genetic susceptibility to cancer. When we look at breast cancer and these risk factors, the risk is variable. We know that breast cancer risk is very closely related to age, that women who are 70 years old are 10 times as likely to be diagnosed with breast cancer as someone in their 30s. We know that family history has a significant role in breast cancer risk, and it really depends on the number of affected relatives. Breast density also increases breast cancer risk. We're going to look at that in a minute. Hormone replacement therapy, as we talked about, therapeutic radiation. Obesity has a very significant role in breast cancer risk, and as does regular alcohol use. I get many questions about breast density and breast cancer risk, and here's an example of what breast density looks like. This level 1 is an entirely fat replaced breast, which is more easily screened and is associated with a lower risk of breast cancer, as opposed to an extremely dense breast, which lowers the sensitivity of mammography, but is also associated with an increased risk for breast cancer. When we think about breast cancer and inherited risk related to family history, we know that if we look at the total number of breast cancer cases, 70 to 80% of them are unrelated to family history, where a family history is associated with up to 20% of cases. And of those cases, we know hereditary breast cancers make up 5 to 10% of the total. So how do we estimate individual breast cancer risk? There are a number of statistical models. And I think we're probably all familiar. I've heard the quote that all statistical models are wrong, but some are useful. And here's one that is particularly useful. This is called the Tyrer-Cuzick model that takes into account some of the things we just talked about. Age at menarche, height and weight, childbirth, previous biopsies and their results, breast density, and family history. We can enter these into this model and then calculate a breast cancer risk for individual patients. We have guidelines for management patients who are considered at increased risk for breast cancer, and that has been defined by expert opinion at a lifetime risk of greater than 20%. For women who fall into this group, we might consider advanced screening, which would include both mammogram and breast MRI. We use elements from the family history and the patient's personal history to decide the age to begin screening. And most guidelines suggest that we stop screening within 10 years of the end of life. I just wanted to share this picture of a screening breast MRI from a recent patient of mine. This was a patient who in her mid-30s was diagnosed with pancreatic cancer and treated successfully and was a long-term survivor. She had been undergoing routine screening when her endocrinologist suggests that she get genetic testing, and she was found to have a mutation in a BRCA gene. She came to see me and we got a breast MRI for screening. And despite having a very normal looking mammogram, she had this area on her of enhancement on her breast MRI that was an occult breast cancer. And so this is an example of how screening MRI adds to our ability to screen high-risk patients. So my professional society, which is the American Society of Breast Surgeons, along with the American College of Radiologists, have now moved towards a model of recommending risk-based breast cancer screening, which includes a risk assessment for all women by the age of 30 to determine if you're at average risk or higher than average risk, and how women should be screened based on their individual risk assessment. It's a move from age-based screening to risk-based screening. And at women who are higher than average risk, we recommend starting with a mammogram and breast MRI. The MRI can start at a younger age at 25 if needed, if the family history suggests that, or if there's a genetic syndrome that suggests that. And also that women with a prior history of breast cancer at a young age and with non-dense breasts versus dense breasts, that we might add MRI for women with dense breasts. So we know that genetics plays a role in breast cancer risk, and that of those cases where genetics, where there's a mutation in a breast cancer gene, that the majority of the mutations that we identify associated with breast cancer are two genes, BRCA1 and 2, although there are several other genetic syndromes associated with increased breast cancer risk. When we look at those genes, we make a plan for both screening and prevention for patients with genetic syndromes. We consider how penetrant the gene is. How likely is a patient to develop cancer if they have a mutation in that gene? And so for the very high penetrance genes, where there's a very high risk of cancer, we find those to be less common. And those genes include BRCA1 and 2, which are more commonly known, other genetic syndromes, including P53 and P10. The moderate penetrance genes, ATM, PALB2, and CHEK2, have a lower risk of breast cancer associated with them, but they're much more common in the population. And I just saw a very busy clinic today, and I saw examples of patients with all three of those mutations. So when we talk about breast cancer prevention, we can identify a group of women where we might consider treatment to help reduce their lifetime risk of breast cancer. The chemo prevention criteria that are commonly accepted include women who are older than age 35, who have a life expectancy of at least 10 years, and have one of these high-risk factors. We talked about thoracic radiation for treatment, especially if you're young, a history of lobular carcinoma in situ, a predicted 5-year cancer risk. We looked at one model called the Gale model. Called the Tyrer-Cuzick model earlier. There's also the Gale model, which is predictive of 5-year cancer risk. Or any woman who has a biopsy that shows atypical cells or atypical hyperplasia. As we start to talk about prevention, I just wanted to clarify a couple definitions. The first one is chemo prevention. which is the use of drugs, vitamins, or other agents to reduce cancer risk, to delay the development or recurrence of cancer. We have two types of medications we currently use for chemo prevention. The first is selective estrogen response modifiers. This is a drug you might have heard of called Tamoxifen or Raloxifene. These block estrogen at its receptor. The other class of drugs we might use are called the aromatase inhibitors, and these reduce estrogen levels in the body for women who are postmenopausal by blocking an enzyme called aromatase. This is a quick diagram that just shows the difference of tamoxifen would block the binding of estrogens to the receptor on the cells. The aromatase inhibitors block the production of estrogens by the peripheral fat cells in the body, which is the primary source of estrogen after menopause. So there have been several studies that have been done looking at these medications for breast cancer prevention. These have been summarized in a meta-analysis by the US Public Health Task Force. It's kind of a busy slide, but you can see over here in this column that when you take these studies all together, it basically favors treatment, showing that these medications are effective in reducing breast cancer risk. And there's a recent trial that we're all very excited about that looked at low-dose tamoxifen for prevention of breast cancer. So many women who are at increased risk for cancer, where we recommend medical therapy, will often have symptoms or side effects related to therapy that limits its use. The dose of tamoxifen that we use for treatment of cancer patients and that was used in the initial trials was 20 milligrams a day. The newest trial looked at a dose of 5 milligrams a day. And would that lower dose still be effective for cancer prevention? It was a randomized trial conducted at multiple sites that included 500 women who had a diagnosis of atypical abnormal cells on a biopsy or lobular carcinoma in situ. They were given 5 milligrams of tamoxifen a day for 3 years or a placebo, and then they were followed for 5 years. Just a quick look at the data. If you look at the graphs here, these looked at the rates of breast cancer, comparing the women who took placebo, which is the blue line, to women who took tamoxifen, which is the red line. And it showed that tamoxifen prevented about half of the episodes of breast cancer in these patients. Even better, if you look over here, it showed that of the adverse events that can be associated with tamoxifen, including a DVT or pulmonary embolism or uterine tumors, that it appeared that this lower dose of tamoxifen was as safe as placebo. So this gives us a new effective tool for risk reduction. And of course, as a surgeon, I would need to talk about surgery for risk reduction. We only use this for patients with a BRCA1 mutation who have the highest risk of breast cancer, related to that previous graph that we looked at. So the studies that have looked at surgery for risk reduction have only looked at this very high-risk population. And in the large studies that have been combined and looked at together, the risk reduction by performing a preventive mastectomy is greater than 95%. And we know that there's also a mortality benefit for these patients, that they live longer and do better. I just wanted to show a brief picture of a nipple-sparing mastectomy because many patients have a lot of questions about this when we talk about this operation. And I thought that this picture from from this publication was very useful to show that when we do this procedure, we can spare the entire skin pocket and the nipple, that we can do a reconstruction with a collagen matrix with an implant, or we can use the patient's own tissue to reconstruct and get a very good cosmetic result, and also have a very safe result for patients. And that we can take this into different types of surgeries now, and we can really craft an operation to help meet every patient's needs. Sometimes they're staged operations, Sometimes we reduce the skin pocket or change the shape of the skin pocket, but can always come up with a reconstruction plan that works well for patients. And then I would be remiss if I didn't talk about primary prevention. I'm just at the end of my time, and so I'm just going to mention the importance of the plant-based diet. We do have multiple studies that demonstrate that a diet that focuses on at least 5 servings of fruits and vegetables a day, we know helps reduce future breast cancer risk. So with that, I'm not going to go over my time, and thank you for your attention.
Dr. Lynch, thank you for such a nice talk. To our attendees, feel free to enter your questions for Dr. Lynch into the Q&A. I would like to now introduce Dr. Xavier Lohr. Dr. Lohr is a gastroenterologist and the director of the Smilow Cancer Genetics and Prevention Program. He's also the director of the Colorectal Cancer Prevention Program at Yale University and Smilow Cancer Hospital and associate director for cancer screening. Thank you for joining us, Dr. Lohr.
Thank you very much, Claire. It's a pleasure to be here today. Let me see if we can share the screen. Can we see well? All right. I have no disclosures to make. So when we're thinking about cancer predisposition and genetic defects, by now we know that it's about over 100 genes that they have been discovered that they carry either a high or moderate risk of cancer, really defined as greater than 2-fold relative risk of having any type of cancer. So a significant number of these genetic defects, and they do affect many different organs, implying a higher risk of cancer. When we look at the colorectal cancer specifically, and we look at the entire pie of colorectal cancers, what we'll see is that about 5% or a little bit over 5% of all colorectal cancers will have an underlying high penetrance mutation, germline mutation, that would predispose to a higher risk of colorectal cancer, and about another 5% or so that would have moderate penetrance mutations, the ones that increase the risk, but not to the level of the high penetrance mutations. And if we look at this first group of the high penetrance mutations, the more predominant ones are the ones that cause Lynch syndrome, the ones due to germline mutations in the mismatch repair genes. And then at a lower number, but also very important, the ones that do cause polyposis, particularly APC or biallelic mutations in the MYH gene. We also find other mutations that are not as clearly well established as causing colorectal or increasing colorectal cancer risk. And among the moderate ones, we do have particularly a specific mutation in APC, the I1307K mutation, for instance, JAK2 mutations or monoallelic MYH mutations that, again, those increase the risk, but not to the level of the high risk or the high penetrance mutations that we see with Lynch syndrome, for instance, or FAP. And this is true for the overall group of individuals with colorectal cancer, and certainly it's true for the individuals that are older than 50, which are the majority of these patients. So in general, about 10% will have these germline mutations, and then 90% of them would not have these mutations. But if we look at younger individuals, for instance, individuals who are younger than 50 who develop colorectal cancer, the proportion of individuals that will have a germline mutation related to cancer risk will be higher. That will go up to close to 20%, being 10% Lynch syndrome. And if we look even at a lower age, looking at individuals who are younger than 35, then here we'll see that about 45% of those individuals will have a germline mutation. That's why it's so important that as individuals are diagnosed at a younger and younger age, we really do genetic testing on these individuals, because their chances of having an inherited cancer syndrome will be much, much higher than individuals who develop those cancers at an older age. And we've looked at the representation among the colon cancers of these cases, but what is the true actual incidence among the general population? So for the most common colon cancer syndrome, which would be Lynch syndrome, as we mentioned, 1 in 279 individuals, not people with cancer, but any individuals will have a mutation in any one of these mismatch repair genes that cause Lynch syndrome. So that means that more than 1 million Americans do have Lynch syndrome. Many of them have not been diagnosed yet, and there's plenty of work to be done in that scenario. On the other hand, important to point out that actually the mutations in the mismatch repair genes that cause Lynch syndrome that are more common, which are MSH6 and particularly PMS2, those are the ones that carry a lower penetrance, meaning they have a lower risk of cancer. That complicates things a little bit. So we have some genes that are less commonly mutated, but they have a much higher risk of cancer. And then some others that are more common, but yet their risk of cancer is not as high as with the other ones. So that's also important to keep in mind, and we'll see in a minute how we are looking at this differently depending on the genes. For the most part, the majority of the colon cancer syndromes are autosomal dominant, polyposis, attenuated forms, Lynch syndrome, those are autosomal dominant, maybe meaning that a single allele, a mutation inherited either from mom or dad is enough to carry that mutation that causes the syndrome. That's the majority, again, of the colon cancer syndromes. But then there's a couple of them. One is MAP, and we'll talk about it in a second. And then this MTHL1, where those are autosomal recessive diseases. That means that we need to inherit one mutated copy from mom and one from dad in order to really have the disease. Those are, again, less common. The majority of the colon cancer syndromes are autosomal dominant. So let's go a little bit over about Lynch syndrome and what we can do once we have it diagnosed. So the etiology, we talked about it. It's a mutation in the germline. That means that it's inherited in any one of these genes that are called mismatch repair genes. Autosomal dominant, as we mentioned, with variable penetrance, and we'll go through this in a second. And the mean age of diagnosis is widely variable, as we'll also see in a minute, but in general, lower than sporadic colorectal cancer. So we will see, as we saw before, that many of these younger individuals will have a higher percentage of cases that will have Lynch syndrome as opposed to older individuals. Only a few polyps or none, and that's a problem that we often see many times because there are no polyps in. People think that there'll be no risk for developing colon cancer, and in fact, it has very little to do with the number of polyps and development of cancer and Lynch syndrome. So it's never a marker for that at all, and we don't pay much attention to it at all. More right-side tumors than sporadic colon cancers. In general, it's 70% of the sporadic colon cancers do happen in the distal part of the colon, rectum, sigmoid, and the left side of the colon. Yet in Lynch syndrome, it's more like a half and half. So many more right-sided tumors, which do have implications when it comes to screening and surveillance. And very rapid cancer development. That's a key characteristic that cancers do develop very fast. Within 2 to 3 years, we can go from an early lesion to a cancer. And that really informs how we do screening and surveillance for those individuals. High risk of having a second cancer, in this case, a second colon cancer, 30% at 10 years after the first diagnosis. That's why it is very important to either do very enhanced surveillance or even proceed with colectomy after we have a diagnosis of a colon cancer related with Lynch syndrome. And truly, this is not a colon cancer syndrome. This is a multi-cancer syndrome with higher risk for cancer from endometrial, but also ovarian, stomach, small bowel, hepatobiliary. There are a different number of types of cancers that have an increased risk, and we'll see in a minute right here. And so over the last few years, what we really learned is that Lynch syndrome does have many flavors, and those really depend a lot on the type of mutation that we have. Here we have the 4 genes implicated in Lynch syndrome. Here on the left side, we have the column with the different cancer sites. And then on the right side here, we have the cumulative risk for that for diagnosis through a lifetime for the general population, just for comparison purposes. And as you'll see here, for colorectal cancer, very high risk in MLH1, MSH2 carriers, a little bit less for MSH6, and definitely a lower risk for PMS2, definitely much higher than the general population. General population 4.2% over a lifetime. And here PMS2 up to 20%, but definitely less than the other one. So that's, also we mentioned that is a difference that we take into account. Endometrial cancer, there are important differences too, also with the lower percentage of individuals developing it when they have PMS2 mutations. And then there are also very unique cases, for instance, when it comes to the urothelial tract, renal pelvis, ureter, bladder, where we see kind of a clustering of the individuals and families with these cancers in mutation carriers for the MSH2 genes. So that's where they really tend to concentrate. Or, for instance, in pancreas, where this really has been much more clearly associated with MLH1 mutation carriers and much less with the other ones, and definitely not with PMS2. So we're left with those very important differences that really are informing us on how we are approaching Lynch syndrome. Again, we no longer call it Lynch syndrome as a whole, and we tend to say more like MLH1 related Lynch syndrome or PMS2 related Lynch syndrome, just because they seem to have important enough differences as you are seeing here. And when we look at this one, PMS2, which as we mentioned is the one that is the most common of them all, the risk is really concentrated in colorectal and endometrial, plus minus for ovarian, and definitely does not seem that there's an increased risk for all these other cancers. So our surveillance is definitely different looking at these cancer risk. When we are looking at average age at presentation, important differences here too. And when we look at colon, that's younger for MLH1 and MSH2 mutation carriers, yet it's older for MSH6 and particularly for PMS2 individuals. And if you look at here at the bracket here for PMS2, 61 to 66, it's important to remember right now, last year, the average age of colorectal cancer had gone down to 67 in the US population. So that's pretty close to what we would see with PMS2 mutation carriers. So many times you'll see individuals with Lynch syndrome due to a PMS2 mutation. That it will be not very spectacular, and the age of onset is not going to be that different from the general population, and often we may not even suspect that the patient can actually have Lynch syndrome. When it comes to endometrial cancers, ages seem to be a little bit more equal here when it comes to age of presentation of these cancers around all the different genes. So what do we do in terms of surveillance? So for colorectal, we do start with high quality, and meaning high quality colonoscopy, what it really means is that we need to make sure that the preparation is adequate and optimal. And also that endoscopies do spend the time really carefully looking at the colon to make sure that we're not missing on anything, because again, particularly right side lesions often would start very flat and may be easily missed, and in 2 or 3 years we have a full-blown cancer there. So very, very important the quality of the colonoscopy, beginning at ages 20 to 25, but 30 to 35 for the mutation carriers of MSH6 and PMS2, just because of what we were showing before, which is that they tend to present later in life. Or if 2 to 5 years prior to the earliest colorectal cancer in the family, if that was diagnosed before the age of 25, or again, 30 for MSH6 or PMS2 carriers. So looking at the specific genetic defect and also the family history and what's happened with them. And we repeat it every 1 to 2 years. And again, the reason for that is because of how fast cancers do develop. And there are good studies showing that repeating it every 1 to 2 years, the great majority of the cancers get caught right on time at an early stage, the majority being able to be taken out endoscopically and then causing minimum disruption doing it this way and not finding them advanced cancers. When it comes to stomach and small bowel cancer, we've seen a lot of variability depending on the continent, and that repeats everywhere actually. So the incidence of overall incidence in the different regions of the world does also play a role in the development of cancer in Lynch syndrome patients too. So for instance, here in the US, the risk is not that spectacularly high, and surveillance has really not been shown to make a significant difference because again, because of the risk not being that high. But certainly for individuals or families who are of Asian descent, we definitely ask for EGD with extended duodenoscopy every 3 to 5 years, beginning at 40 and every 3 to 5 years. And there's some recent data that probably suggests that for the given the small risk and the little that is added, adding an EGD to our colonoscopy probably does make sense to do that for the overall population. But again, there's no strong data showing that. Baseline Helicobacter pylori testing and eradication, we do that. We do not want two carcinogens. Helicobacter pylori underlines gastric cancer, and certainly we don't like to have a carcinogen on top of a susceptibility of colorectal gastric cancer. So we try to test and eliminate in all individuals who test positive. When it comes to endometrial cancer, no good data proving benefit from screening. But we do know that endometrial biopsies are highly sensitive and specific as diagnostic procedures, and that's what's being used every 1 to 2 years, starting at age 30 to 35. Transvaginal ultrasound, which is used for ovarian cancer in premenopausal women, is not recommended. And hysterectomy is definitely a risk-reducing option that works well and it's been well proven. And it really needs to be timed in an individualized way, and really trying to see if that can be done right after childbearing age is completed. But family history is important and genetic defect is important in order to really putting it all together and counseling on when it's the right time for that hysterectomy. For ovarian cancer, we mentioned before, transvaginal ultrasound or CA-125 are being used. And we do know also that bilateral salpingophorectomy definitely would reduce the incidence of ovarian cancer. And we would not do it for PMS2 carriers because probably there's no increased risk in this group as we saw before. For pancreas cancer, as we mentioned before, very clustered around MLH1 about this gene. And that's the one that when there's a family member who's had pancreas cancer, and have that mutation, we really recommend screening starting at age 50 or 10 years earlier than the youngest pancreas cancer in the family for individuals with more than one first or second degree relative with pancreas adenocarcinoma. GU, still very unclear. Remember, we talked that there's a lot of clustering around the MSH2 gene, and no clear evidence to support screening, but annual urinalysis is usually done. It's a cheap method, and there's some sporadic data that shows that that's been able to help in terms of identifying early lesions. For CNS cancer, which also for Lynch syndrome, there's a slightly increased risk. Annual physical examinations with a neurological exam starting at age 25 and 30 is recommended, and yet we don't have strong data on that, and particularly because the risk is not that extraordinarily high. How about surgical management? For once colon cancer is diagnosed, there should be strong consideration for subtotal or subtotal colectomy. And ileorectal anastomosis, and that's because, again, what we mentioned before of the very high risk of developing another cancer. So it is important that surgeons do have a diagnosis before they operate. But again, as we mentioned before, if our patients are gonna be very compliant and willing to have this colonoscopy every 1 to 2 years, that's a reasonable option too. But again, knowing that we do have a pretty high risk once we had one colon cancer of developing a second one. Prophylactic surgery, definitely, as we mentioned before, hysterectomy and oophorectomy should be discussed with mutation carriers after completion of childbearing age, or also depending on the family history and situation, that could be even earlier. And we do know that that reduces endometrial and ovarian cancer. Prophylactic colectomy has not been recommended, but chemoprophylaxis is used, and we do use that. We have good data on 2 adult aspirins a day for at least a year and a half of continued intake every day, with a significant reduction in colorectal cancer. The problem is that toxicity of 2 adult aspirins is quite significant, particularly among the older individuals. So we do individualize the option here. And also we're really pending on more data on lower doses, particularly now that our studies are looking at 1 adult aspirin and 1 baby aspirin a day, see if they do have that effect, because certainly a baby aspirin has been shown to reduce colorectal cancer in the sporadic population quite dramatically. So we're hoping that lower doses will also have a significant effect among individuals who have Lynch syndrome. Switching gears, much less common, but certainly a very significant morbidity and mortality. And this APC gene that's causing familial adenomatous polyposis was the very first gene that was identified to cause a GI cancer syndrome. This is an autosomal dominant disease again, so we just 1 mutated allele is enough to cause the disease. Individuals develop hundreds to thousands of adenomatous polyps. The penetrance is very, very high for both adenomas and cancer, almost everyone, if we don't remove the colon. And cancer develops again in almost 100% of cases by the 40s if there's no colectomy before that. The onset of the disease usually in the teens, and de novo mutations are common. Close to 30% we may see a de novo mutation, meaning that there is no family history, and all of a sudden this patient does have that mutation. From that on, this individual can transmit that mutation to the offspring. So that's very different from Lynch syndrome, where the immense majority of the cases are found in mutations that have been that happened many generations ago. So there's almost always a family history and family members who will have the mutation. When it comes to cancers in FAP, the great majority of individuals will have their colectomy before they develop cancer, and they do well. But this is really the biggest nightmare for us, taking care of these patients, which are the duodenal cancers. 5 to 11% of these individuals do develop these cancers, and they are important cause of morbidity and the most important cause of mortality nowadays. There are other cancers like pancreas or thyroid or medulloblastoma and hepatoblastoma, particularly in very, very young kids, but the risks are not extremely high. But anyways, something to pay attention to. And interestingly, there's this kind of loose association that we call genotype-phenotype, meaning depending on where the genetic defect in this gene is, we may have different manifestations. For instance, desmoid tumors, this connective tissue tumors that often can be a true nightmare for patients with FAP because of their mass effect pushes other organs, particularly in the abdomen. Those are usually clustered in the 3' region of the gene with other characteristics like Garner syndrome with soft tissue tumors. That those will be much more often seen when they are found in mutations in what we call the mutator cluster region in the exon, the last exon of the gene. So attenuated forms usually clustering and mutations in the 5' end of the gene too. So there's some correlation between where the mutation is and what the actual phenotype is, though this is far from perfect. And this is a little bit harder. FAP, arguably almost anyone, when we see all these polyps, we really suspect easily that the patient may have FAP, but attenuated FAP is a much more complicated issue. Usually it's less than 100 polyps located predominantly in the right colon. And those are polyps that add up over time. And many times we do see patients who develop 20 polyps now and 15 polyps later. And often we just don't add it up and say, well, this is looking like there is something going on, and it may be a form of attenuated polyposis. So important to suspect when we have particularly a number of polyps that's in the 20s, 30s, because then suspicion for that should be high. The onset of polyps and cancers is usually 10 years later on average than FAP. But again, there's a lot of variability here. And these individuals do also develop funding gland polyps often in the stomach, and they can precede the development of colon polyps. So particularly when we do endoscopies where we see funding gland polyps in individuals who do not have proton pump inhibitors, those anti-acid strong anti-acid medications, which they also cause funding gland polyps, then we suspect that there could be some form of polyposis, and we need to pursue that. So what do we do when we have a diagnosed individual with a mutation in the APC gene? Well, we start colonoscopies at age 10 to 15 and every 12 months. And once the number of polyps becomes too overwhelming to be able to really keep up removing those polyps, then that's when surgery is indicated in those cases. And there are two options. One of them is colectomy with ileorectal anastomosis. Particularly the rectum is not very affected with a lot of polyps, and then the rectum needs surveillance every 6 to 12 months with sigmoidoscopy. Or the other option is ileal pouch anal anastomosis, and in this case the rectum is gone too, but what the pouch, which is made of small bowel, does develop, or does often develop polyps in there too, and that needs surveillance as much as the other, as much as the colorectal anastomosis wants to. And if there are large or flat lesions, or lesions with villous histology or high-grade dysplasia, then those need a much closer surveillance. When it comes to duodenal or periampullary cancer, again, small bowel cancer is one of the biggest nightmares that we have with FAP patients. We do upper endoscopies with side viewing scopes to make sure that we see well the ampulla of Vater, which is one of the main problems developing adenomas and later cancers in that area. And we do starting at around age 20 to 25. For gastric cancer prevention, as we mentioned, many of these patients with FAP do have funded gland polyps. And if they have even focal low-grade dysplasia, and none of them are particularly large, they tend to be very benign, and they won't transform into cancer. Now, if we see some of them that are too large or larger than 1 centimeter, or they have high-grade dysplasia, then the risk of cancer does increase, and we may end up even indicating gastrectomy. So very important to follow that up, even though the majority of cases do behave in a benign way. And for thyroid cancer risks, the recommendation is ultrasounds and repeating them every 2 to 5 years. Just to make sure we're not missing anything there. For the attenuated forms, it really, what informs what we do really depends on the polyp burden. And as we mentioned, there's a great variability. Some of them have a polyp burden that is very relatively easy to handle endoscopically, meaning that we can remove a good number of polyps every time we do colonoscopy. Then we just do colonoscopies and polypectomies every 1 to 2 years. And in many cases, we'll be able to keep up with those polyps, and there'll be no need for surgery. Upper endoscopy, again, needs to be done for the small bowel cancer risk and adenomas. And chemo prevention is another option here, and Sulindac is the most well-established one. And this is particularly used and is very much focused on individuals who already had surgery and who have either a remaining rectum or pouch to try to reduce the development of polyps in this area. when we have a polyp burden that we just can't handle endoscopically anymore, then that's when we will suggest colectomy again with either ileorectal anastomosis or proctocolectomy and the creation of the pouch. So it's really how the patient behaves in terms of how many polyps the patient develops, how fast they develop, and that will really informs us if we can really keep up with removal endoscopically, or at some point we decide that that's not safe anymore and we need to proceed with the surgery. This is the newer polyposis, or one of the newer polyposis syndromes that we're less familiar with, that we call MAP or MYH associated polyposis. Remember, we talked that this is an autosomal recessive, meaning that we do need mom and that the bad gene from mom and the bad gene from dad in order to really have the disease. That means that most of the time we would skip generations. So mom and dad would not have the disease, yet you could have siblings who would have it if they inherited both bad genes from mom and dad. So about a third, close to a third of patients who have a typical familial adenomatous polyposis phenotype, they look like adenomatous polyposis and do not have an APC mutation. What they will have is actually these two mutations in the MYH gene. And a quarter of the patients who have between 10 and 100 with a mean of 30 polyps will have biallelic mutations in MYH. So particularly in these individuals that look more like attenuated polyposis, that's where the line is a little bit blurred with the attenuated forms of APC. The age of onset, 40s, 50s, risk of cancer, very, very high, almost complete penetrance by age 60, not 40 like in FAP, but by age 60, the great majority if they did not have their polyps removed or surgery removed. And the main differences between FAP and MAP, again, the dominant pattern versus recessive pattern for MAP. Number of polyps, again, for FAP, typical FAP, more than 100 polyps. For MAP, a smaller number, less than 100 many times. Age of diagnosis, older for MAP. And a big difference in extracolonic disease, particularly upper GI tract adenomas and cancer, as opposed to the very, very high numbers for FAP, and desmoid tumors, the same thing. So much, much lower incidence of both upper GI tract cancers and desmoid tumors. Big difference from that standpoint. But risks certainly very, very high for colorectal cancer, as we saw before for both FAP and MAP. And the treatment and surveillance is really very, very much the same as what we do with attenuated FAP, which again, if we can keep up with the polyp burden through endoscopic removal, that's what we'll do. And if at some point that's not feasible anymore, that's when we'll suggest surgery. So not much different from the attenuated forms. Finally, serrated polyposis syndrome. This is a serrated polyp on the right side of the colon. This is a syndrome that we've defined for years, and yet at this point we really don't have a genetic defect that's associated with it. There's some genes have been loosely associated with it, but really no strong data on that either, which makes things very challenging when it comes to really having a unified approach to a disease when we really don't have a clear etiology. The inheritance pattern is unclear. Some data has pointed at autosomal dominant type of pattern, but other data has pointed towards an autosomal recessive pattern, so really still unclear. And adenomas in these cases do coexist with serrated polyps too, so it's not all about serrated polyps, and most of the time we'll find a mixed pattern of polyps. The mean age of colorectal cancer diagnosis is 55, and relative risk of cancer 5.4 on average. And there seems to be some different phenotypes, some of them being more severe with large right side sessile-serrated adenomas and young age of onset. But again, every time that we don't have a specific gene that's behind a disease, often it's a little bit more challenging to really have a unified idea of what's going on. And we've gone by these clinical criteria that were originally set up by the World Gastroenterology Organization that were revised in 2019 were basically is looking at number of serrated lesions in the colon and the size of these lesions that will really kind of help us classify if patients do have serrated polyposis or not. There's nothing magic about these criteria. And actually the criteria got a little bit loosened because we're missing a lot of cases that were not fulfilling the 2010 criteria, and yet they were developing cancer at similar rate as the other ones. Therefore, that's how that got changed. And the biggest change was really counting serrated and hyperplastic lesions proximal to the rectum instead of proximal to the sigmoid colon when it comes to accounting for these lesions for the serrated polyposis syndrome. So what do we do in terms of surveillance? Colonoscopy with polypectomy until all polyps that are larger than 5 millimeters are removed. And then with that more clear colon, we would repeat colonoscopy every 1 to 3 years, depending on number and size of polyps. And certainly if there's no good way to keep up with those polyps, and again, it's tricky because some of these are very flat and hard to see sometimes, then consider surgical referral, particularly if we find evidence of high-grade dysplasia in those cases. So this is a list of polyposis syndromes that, as you can see, the number of genes that are associated with them has grown over the last few years, even though many of them are really not that frequent. We've mentioned about APC causing FAP and the attenuated form, MYH causing MAP. Then this is much less common, this P-PAPO polymerase proliferating associated polyposis due to these genetic germline defects. GRAM1 for hereditary mixed polyposis, or these other NTHL1, and then the hamartomatous polyposis that we've known for years because of their very unique phenotypes, Brooks-Jaggers, juvenile polyposis, P10 hamartoma tumor syndrome, Cowden, for instance. Those I'm not going to get into right now. So basically, I think just to leave you with this, that when it comes to polyposis, things are not more often not clear-cut. We may have FAP patients who would have not only adenomatous polyps, but also serrated polyps. Serrated polyposis usually does include a lot of patients or patients who have not only serrated polyps, but also adenomatous polyps. So a mixed type of polyps is very commonly seen in many of those syndromes. And I'm so grateful. And that's important to remember. And I will leave it here, and at the end, I'll be happy to take any questions. Thank you very much.
All right, thank you so much, Dr. Lohr. Next, I'd like to introduce Dr. James Farrell. Dr. Farrell is an expert in pancreatic disease treatment and research. He is board certified in internal medicine, gastroenterology, and clinical pharmacology. He leads the Yale Center for Pancreatic Disease at Yale School of Medicine and Yale New Haven Hospital, as well as the Yale Interventional Endoscopy Program. Thank you for joining us, Dr. Farrell. Dr. Farrell, are you there?
Can you hear me?
Yes, perfect.
Perfect,
Thank
great.
you.
Let me get my slides up. Okay, great. Let me just turn my... Again, good evening, everybody. Thanks for the invitation to participate again this year in this mini symposium. I had actually really only planned to talk for about 10 or 15 minutes because it's late, and I'm sure there's other speakers as well. So I'm probably going to keep my comments fairly brief and just cover some of the issues related to screening and prevention for high-risk pancreas cancer but obviously ultimately focusing on the high-risk genetics cases. And because it's not as a mature a topic as perhaps in the realm of colon cancer, what you heard about, or breast or ovarian cancer, you'll see a lot of it is still under kind of the context of research. And I've added my contact information in the last slide if anybody wants to reach out to me with any additional questions. So let me just put this. Sorry. Let me get rid of this. There's an annoying bar on my, I can get rid of that. Is that bar on your screen too? Oh, here we go. Okay. I'll put that. Okay, put that down there. Okay. So when we think of, just to remind people, when we think of pancreatic cancer, you know, compared to some of the other there we go. We compared with some of the other cancers that we think of, the overall incidence of pancreatic cancer is actually, you know, it's low on the list, number 9 or 10 for both men and women. But the real challenge is, of course, when it comes to cancer-related deaths, and it jumps up into the list to the number 3 or number 4 spot. And so, you know, with an average of around 56,000 cases in the current year, it's guesstimated that by 2030 or so, pancreatic cancer will be the second most common cause for cancer-related deaths. You know, and a lot of that has to do with more progress that's made in other areas of treatment, and particularly prevention, and less so with pancreatic cancer, although there have been some advances in both the areas of treatment and prevention, but just not as dramatic as with other malignancies. So a huge challenge. I think it's also worth stating that it's important to kind of understand the different stages for pancreatic cancer, because this is one of the issues that we have with any sort of surveillance strategy. And so for this particular patient, this is a CT scan. And so for this particular patient, this is a small pancreatic cancer involving the head of the pancreas, probably the order of 1.5 to 2 centimeters or so in size. And these are important blood vessels around it, but this mass is actually somewhat distinct from these blood vessels. And so typically a surgeon would be able to remove this. So even though the nomenclature can be quite confusing, this is in a very straightforward way we think about in terms of resectable pancreatic cancer. You see the liver over here on the left side, and the kidneys as well. Now, if you move on from that a little bit, and again, looking at another CT scan, you can see in the arrow here another large mass. But now this mass is beginning to involve and encase a blood vessel, an important blood vessel here. And for this reason, even though you say, well, it's still confined to the pancreas, or at least the head of the pancreas, because of its involvement in a blood vessel, this makes it more difficult for a surgeon to consider removing this. Again, there may not be evidence, at least to the visible eye, of disease elsewhere in the liver and so on, but this still would not be considered surgically resectable in its current state. And so we call this locally advanced disease. And then the most dramatic stage, of course, is individuals who present with disease outside of the pancreas at the time of presentation. Often it's in the liver, sometimes it's up in the chest, and often sometimes then again it's in what's called the peritoneum, so implants here shown on this CT scan. So again, this would not be considered surgically resectable or removable disease, and would in fact be considered metastatic disease. To put this into some perspective then, only about 15% of all patients present with that surgically resectable stage, an early stage that a surgeon can go in and remove. And this is the group of patients that really offer the best potential for those that present with at the stage with a cancer. And so the mean average survival is in the region of 20-25 months. But of course, there can be extremes with that. For the other two groups, however, it's split somewhat evenly between patients presenting with locally advanced disease as well as metastatic disease. And so it just gets at the important issue that although there are newer treatments and somewhat better medical treatments for this disease than there were, say, 15 or 20 years ago, The real focus to make any sort of dent in this disease is really early detection. And part of that reason where it becomes challenging is because, of course, the symptoms associated with pancreatic cancer are very non-specific. So, if you think about them and how these patients will present at the symptomatic point, at least, abdominal pain, weight loss can be common symptoms, but they're very non-specific. You get abdominal pain from an ulcer, from a gallstone. It doesn't necessarily have to be a pancreatic malignancy. And the same thing for weight loss. When you look at other symptoms like jaundice and dark urine, you could certainly kind of begin to focus in on things related to the pancreas, but still very non-specific. And again, there's other symptoms like nausea, vomiting, depression, anorexia, that again have a multitude of causes, and pancreatic cancer is certainly not high up on that list. Two ones that are also worth thinking about are acute pancreatitis and new onset diabetes. And we'll come back and talk a little bit more about the new onset diabetes later on in terms of ways that patients with pancreatic cancer may present that we should be familiar with. So therefore, when we think about the goals of pancreatic cancer screening, it has been stated in guidelines that a successful screening program should detect and treat what's considered early stage or resectable margin negative, so there's no tumor left behind, pancreatic cancer, as well as lesions that are not cancerous, so-called precancerous lesions. And these include a variety of very well-established pathologic entities called PANNs or IPMNs or MCNs. These are sometimes types of cysts in the pancreas. And some of them do have imaging correlates that can be seen on a CT scan, but unfortunately some of them don't, and it can be quite difficult to identify. But ideally, picking up high-grade dysplastic precancerous lesions would really be a huge step forward in the management and prognosis for this group of patients. So without getting into it in too much detail, I'll just state very briefly that we do not perform general screening in the general population. There's a variety of reasons for that. There is no simple single blood test that, if you have no risk factors related to pancreatic disease, you can get. It's not to say people aren't working in that direction, but it's a very challenging area. And so right now, we don't offer or talk about necessarily general screening for the general population. What we do focus on is trying to study and enriching groups. And the three major groups that we study and that we think about when we think about pancreatic cancer surveillance are pancreatic cysts, diabetes, and then familial pancreatic cancer. Very briefly, I'm not going to spend much time talking about pancreatic cysts, but pancreatic cysts are exceedingly common. So anywhere between 10 to 40% of CT scans and MRIs that are done for patients coming into hospital will have a small cyst. The vast majority of those cysts will not develop into cancer, but most of those cysts can actually be considered precancerous. When you think at a national level, it's guesstimated that probably around 6 million individuals in the US have some form of pancreatic cyst. So it's not a small trivial issue. The risk may be low, but kind of on a global scale, it adds up. And so it's something that we certainly take note of and have guidelines in place to try and manage this. Not necessarily the new kid on the block, but something that you're going to hear more and more about is the interplay between diabetes and pancreatic cancer. So for sure, for individuals with diabetes, it's well known that they are at a slightly increased risk of developing pancreatic cancer. But probably the much more interesting direction is the idea of pancreatic cancer leading and presenting as diabetes. And this is more than just an issue of the tumor taking over the pancreatic gland. There's some other factors going on here that people are beginning to scratch away at, and a result may provide actually an opportunity for screening. In one prospective case control study that was done of a large number of newly diagnosed pancreatic ductal adenocarcinomas, the vast majority of patients had some form of fasting blood glucose abnormality. Some of them actually had, documented diabetes, and about half of them had what's called new onset diabetes within a period of time before the presentation. So this cannot be ignored. There is something going on with diabetes and pancreatic cancer that's worth studying. When we look at individuals who subsequently have an association between pancreatic ductal adenocarcinoma and elevated blood sugars, certain studies have been able to go back and track the kind of slow rise of blood sugars anywhere up to about 36 months before the clinical presentation of pancreatic cancer. So this then is being translated into another way to try and enrich or find certain populations who are at higher risk for developing pancreatic cancer and study it. And so this is very much at a research level right now, but it's gathering speed. The final and big area that I do want to talk to you about this evening is familial pancreatic cancer. So it's guesstimated that when you think about all patients presenting with pancreatic cancer, about a total of anywhere between 10 or 15% of these patients will have either a familial component, meaning when you ask them about their family history, they'll tell you that they have a, 2 first-degree relatives, 1 first-degree relative, several secondary relatives, and so on. So there's a definite lineage going on in that family when you ask, and often people forget to ask, but I think now people are becoming more aware of that. And then a certain percentage of these patients then will actually have a documented and detectable germline mutation that we can find in the blood that can further kind of steer and guide us about what to do. When we think about familial pancreatic cancer, obviously the more family members that are affected, the greater your relative risk of developing pancreatic cancer. So if you've got 3 first-degree relatives, you have a 32-fold relative risk compared to individuals who don't have that type of family history. If you've got 1 first-degree relative, it's unclear what the significance of that is in terms of whether we act upon it or not. And so it doesn't meet the definitive criteria for saying someone has a familial pancreatic cancer or comes from a familial pancreatic cancer kindred. We certainly take notice, especially when individuals are young in families, but again, having just 1 family member probably does not meet those definite criteria. It's also interesting to note that despite a lot of knowledge about familial pancreatic cancer, the fact that it runs in the family, the entire mode of transmission and inheritance is still unclear. The most common abnormality that's found from a genetic perspective is the BRCA2 mutation, but it's still, as you can see, only found in up to 20% of patients. So it's still not a large number of patients. And there are probably other either genes that haven't been discovered or defined yet, or some other shared environmental issues that we still have to scratch away at. So here is a list of the broad familial syndromes associated with pancreatic cancer. Most of them you will hear about in some other form this evening. We've certainly very commonly talked about BRCA2 and BRCA1, and increasingly recognizing the importance of PALB2 as a player in familial risk for pancreatic cancer. Also Peutz-Jeghers, you heard just Dr. Lohr talk about hereditary non-polyposis colon cancer. A variety of hereditary pancreatitis syndromes have been defined as risk factors for the development of pancreatic cancer. And then P16 has a very large, or FAM, F-A-M-M-M, is a very large risk factor for the development of pancreatic cancer as well. What we actually do for these patients, similar to the other patients that we see with pancreatic cysts, as well as now as we look a little bit more closely at new onset diabetes, is really kind of performed in a multidisciplinary approach. Currently, the standard approach is to start with non-invasive imaging, either a CT scan or preferably an MRI. Depending on what's found, then a certain subgroup of patients will undergo an endoscopic evaluation to take a closer look at the pancreas, to look particularly at cysts, looking for masses, and to biopsy suspicious lesions. And then worrisome groups of patients will ultimately be referred for surgery to remove a portion of the pancreas that is either very concerning or does have a documented cancer associated with it. So this is done in a very prospective, multidisciplinary type of approach. These are the groups of patients that we see in our current high-risk pancreas cancer surveillance program in our early detection clinic. I think about them in terms of 4 broad groups. Peutz-Jeghers, of course, which has a very high risk of developing pancreatic cancer. We talked about the familial pancreatic cancer kindreds. We typically start at the age of 55 or 10 years younger than the youngest individual in the family. And it does require to have 2 or more members with pancreatic cancer, one of which is a first-degree member. So there are some defined criteria. Then there are the better characterized individuals that, again, you're hearing about this evening, the germline mutations that have, but that must have at least one family member with pancreatic cancer. So there is a higher group, which includes P16, BRCA2, PALB2, and now ATM is in that higher group, and a lower risk group that we still study, which includes the BRCA1 population as well as the HNPCC population. But just remember that for the majority of these patients, with the exception of P16, it does require there to be some family history of pancreatic cancer. And then we also mentioned hereditary pancreatitis. Currently, as of this week, we have about 205 patients that we are actively managing and following in our high-risk pancreas surveillance program. And again, you can see the breakdown there. There's a large number that we don't have any sort of germline mutation status, but a fairly large number have some abnormality in a DNA repair gene. Just to kind of look at this and say, this is not as a matured world as what you're hearing for colon cancer and breast cancer, even for ovarian cancer. But it is important to say that there is evolving data, and there does appear to be data that does support surveillance in high-risk individuals from the perspective of an improved outcome associated with those individuals that have cancers detected as part of a surveillance, as opposed to those that just present sporadically or with symptoms. So at least kind of early data to support that this is a good strategy and does hopefully will improve overall survival in this cohort. So I'll finish on that and just summarize, the important point to note is that right now we still don't have and don't recommend general population screening, but it is an area that's being worked on. And there are certain blood tests that are either available or coming down the pipeline trying to address this particular issue. For pancreatic cancer, it's now considered standard of care for the appropriate indication, although we have a variety of research studies that are open that follow this group of patients that involve, again, combinations of imaging with MRI or endoscopic ultrasound over time. We talked about pancreatic cysts as another high-risk group, and it's a big volume issue. And we've opened a study, the ECOG 2185 study here at Yale, to actually study this particular group in terms of surveillance and different surveillance protocols. And I would advise you just to keep your eye on the diabetes space for this, particularly new onset diabetes. And maybe we'll be looking at combining all these risk factors, be it family history, pancreatic cyst, as well as blood sugar levels. I'll also just give a plug for our pancreatic cancer early detection clinic that is based with Dr. Lohr's group at the St. Raphael's campus. And my contact information is there if anybody has any specific questions for us over time. Thank you.
Great. Thank you so much, Dr. Farrell. In the interest of time, we'll quickly move over to Dr. Ratner. Elena Ratner is a board-certified gynecologic oncologist with special interest in chemotherapy-targeted drug development, patient quality of life programs, and early cancer detection. She's the director of the Discovery to Cure Early Ovarian Cancer Detection Program and founder and director of the Sexuality, Intimacy, and Menopause Cancer Survivorship Program. Welcome, Dr. Ratner. Thank you for joining us.
Thank you so much, Claire. It is so great to be here. I'm going to share my screen. Bear with me. This is frequently my Achilles heel. Okay. Oh, this actually seems to have worked. This is lovely. So I have the privilege today to speak to you about yet another component of the screening and early detection in patients who we consider to be at high risk for different cancers, hereditary cancers, and that being ovarian cancer. Oh, hold on one second. Here we go. So the premise of this that many have now spoken before me is the driving hypothesis that many patients may be at increased risk for several cancers based on personal or family history, genetic status, personal history of atypical hyperplasia. And it's so important because so much in our current culture is becoming not about, especially, in particular in ovarian cancer, the conversation now is really no longer about what do we do to cure ovarian cancer. And it's not even as much about early detection, as those two have been so challenging. A lot of conversations currently are about cancer prevention. So that is why this risk assessment is so important, because there are options for either surveillance or risk reduction for these patients and for their family members. And management of these patients up to now has been very, very much piecemeal by a variety of providers in several groups. And this is, very much kind of my passion, again, in particular in ovarian cancer, is that the signs and symptoms of ovarian cancer are so unique, but also so vague, that patients very frequently get seen by different providers who do a great job ruling out their cause of the symptoms, but do not connect the pieces to appreciate that these are signs and symptoms of ovarian cancer. And that is why it's so important that we come up with a comprehensive approach to this patient population. So hereditary cancers, as Claire already discussed, 10% of all cancers, probably higher than that, mutations within a single dominant genes. But of course, again, as Claire discussed, whole exome sequencing, our understanding of cancer genetics is about to change, and this percentage is going to grow. In my population, the risk factors that we look at are early age of onset of cancer, multiple affected family members, related cancers in the family. And again, in the world of ovarian cancer, it is so important that we don't forget that it's not only women and it's not only ovary and breast, that there's many other associated cancers, such as pancreatic cancer, that Dr. Farrell just so beautifully talked about, such as melanoma, such as prostate cancer in males. And for us in the female-only field, it's always very important to remind the patients that when I'm asking them about family history, I'm not just asking about their mom or their grandmother, I'm also asking about the paternal line as well. Multiple primaries, male breast cancer, Jewish ancestry, and then the subtype of the ovarian cancer that they have. So I won't go into this because we already heard so much about that today. So BRCA1, BRCA2 increase the risk of breast, ovarian, prostate, and then BRCA2 increase risk of breast, ovarian, prostate in men, as well as pancreatic cancer and male breast cancer. These genes increase the risk of cancers very substantially. So breast cancer being the most common, as high as 85% for BRCA1, 80% for BRCA2, and then as high as 60% for BRCA1 for the risk of ovarian cancer, and as high as 40% for BRCA2 in ovarian cancer in BRCA2. And the estimated lifetime cancer risks of other cancers, such as pancreatic and prostate male breast, are also, as you know, increased with, again, as high as doubling for prostate cancer, increasing, again, as Dr. Farrell just talked about, and then 5 to 10% in male breast cancer. So I'm going to jump into the gynecologic cancers because, again, you have heard so much already about other cancers at risk for the genetic mutations. So I will talk about ovarian cancer. Ovarian cancer is not the most common gynecologic malignancy. The most common gynecologic malignancy is the uterine cancer, but it's by far the deadliest. There's 22,000 cases that get diagnosed every year, and 15,000 women die every year. So as much as we have tried, this is not for the lack of trying. A lot of research has got into ovarian cancer management. A lot of research has got into chemotherapy regimens and chemotherapy resistance regimens. And we've done so much research and so much advancement in surgical cancer management. I can now do surgeries laparoscopically where women go home same day, where in the past, 5 years back, women would have a huge incision on their bellies and would stay in the hospital longer than a week. So the field is moving and things have been done, but sadly, it has not moved the mortality of this disease, and that is unacceptable. The big part of this challenge in improving the mortality is, again, this fact that unfortunately these cancers continue to be diagnosed at a later stage. I will talk in a little bit about the difficulty of this and why this cancer is diagnosed at a later stage, but most cancers are still diagnosed in stage 3 and stage 4. And the difference in survival between a woman who's diagnosed in stage 1 is life-saving. You know, somebody who's diagnosed in stage 1 has 92 to 95% chance of survival versus only as low as 20% in advanced stages. That is why it is so important for us to try to detect these cancers early, but more importantly, to try to prevent them. So part of the challenge, part of this limitation is that we have always been told, and we have always said that ovarian cancer is the disease that whispers. You know, for generations, we were told, you know, there's just nothing you can do. You can never find these cancers early. They are always like this. There's no symptoms until the disease in stage 3 and stage 4. So there's really nothing that we as a field can do to make it better. But we know that that is very much not the case. We now know that ovarian cancer doesn't necessarily whisper. It's really that a lot of people are not listening to it. And that has to do with awareness on the patient sides, the vagueness of the symptoms, but also some limitations on the provider side as well. So some very good studies came out. This is one of the seminal ones by Barbara Goff from Seattle that talked about that ovarian cancer presents with these specific symptoms: abdominal discomfort, GI discomfort, pain, constitutional, urinary, and pelvic. And even though great majority of them in stage 3 and 4, that 97% of patients in stage 3 and 4 had the symptoms, 89% of women in stage 1 and 2 had those symptoms as well. And this study kind of debulked this whole concept that we have talked about for so long before, that the women in early stage have no symptoms. Barbara Goff very clearly kind of looked into who are the patients who ended up having this ovarian cancer, because honestly, like any of us looking at the symptoms, it looks very concerning because all of us experience these symptoms. But she very much created this assessment, risk assessment for women. And for the women who actually had ovarian cancer, these women had it consistently once every single day for 2 weeks, compared to women who had them every 2 to 3 times per month, and often associated either with ovulation or their menstrual cycles. Also, having more than one symptom was much more associated with ovarian cancer than those women that just had hormonal changes. So this very much was a seminal study, and this, I think, gives us a voice and gives us the opportunity to educate our patients and educate communities about listening to your bodies and knowing when something is not right, and not always just assuming that the symptoms you're experiencing are hormonal symptoms, because if the symptoms are persistent and symptoms are multiple, then you would need to be evaluated to rule this out. So as I mentioned, 25,000 cases, a lot of deaths, most common cause of death by far in women with ovarian cancer, and 4th leading cause of cancer death in the United States. So to talk a little bit more about how these cancers can be prevented, which is really kind of the motif that I want to talk about, is what can we do for prevention? I think it's important to understand who are the women who are at risk for epithelial ovarian cancers, which are the common ovarian cancers. So there's a couple of theories to this. There's actually 2 different theories of ovarian cancer. One, the most common and the oldest, is this incessant ovulation. So the more times that the woman ovulates, the more risk she has on this tumorigenesis, carcinogenesis. So women who have had early menarche, late menopause, who haven't had a lot of children, who didn't breastfeed, and who had infertility due to probably multiple issues, as well as did not use birth control pills. And the reasoning for this is similar, that the more times that you're not ovulating, the less risk there is that this ovulation happen and precipitate some sort of a cancer development. The more recent thinking of ovarian cancer genesis is actually not that the cancer actually comes from the ovaries, but rather the cancer comes from the fallopian tubes. And we actually have a lot of thinking now, especially for women with hereditary germline cancers like a BRCA cancer. We very much believe that the origin of the disease is really in the fallopian tubes. Hereditary ovarian cancer, genetic mutations, of course, is the biggest risk factor to predisposition to ovarian cancer. That is between BRCA1, BRCA2, Lynch, and now newly discovered additional genes. As I mentioned before, women with BRCA1 have as high as 46% chance of ovarian cancer, as high as 23% in BRCA2 carriers, with a lifetime risk in general population of 1.4 to 1.5%, so significantly increased incidence. And this is similar data that shows that the risk of ovarian cancer with BRCA1 and BRCA2 gene mutation, both of breast and of ovarian. So what can be done? What are the factors that can reduce the risk of ovarian cancer? And there's some simple ones. So multiparity, really for the same reasoning that I gave you before, that the more that the woman is pregnant, the less she's ovulating. You have to have 5 children to decrease your risk by 50%. I have 4 children. I'm very close to that benefit. And you have to breastfeed every single one for a year for additional benefit. One of the very big important points of chemo prevention in ovarian cancer is the use of oral contraceptives. And that is something that I talk about incessantly and use every opportunity to communicate this message, because there's a lot of misinformation and lack of knowledge about the use of oral contraceptions in women. But we know, due to that theory that I showed you before about the ovulation that increases risk, that use of OCPs, birth control pills, significantly decreases risk of ovarian cancer. If a woman uses birth control pills for 5 years during her lifetime, doesn't have to be at the same time, could be just cumulative, it decreases her risk by 50%. If she uses it for 10 or 15 years, it can decrease the risk by as high as 80 to 90%. And that risk reduction is not just for general population, it's also for women with BRCA mutations. So if a woman with BRCA1 mutation has a 40% chance of ovarian cancer, and she uses birth control pills for 5 years, that now reduces her risk to 20% and so forth. Tubal ligation, or even better in this day and age, removal of the tubes, is another very significant protective factor. It has relative risk of 0.3, so you can significantly reduce the risk by either tying the tubes or even better removing it. And I think that is something that supports the theory that I talked about, that the cancer might actually be coming from the fallopian tubes. Nowadays, tubal ligation really is a little bit old school. And I, again, thoroughly argue that if you're going to tie tubes, you should just remove them entirely. And anybody who's having a hysterectomy for benign reasons should always have their fallopian tubes removed. I will never leave a fallopian tube behind, because I very much see it as a very significant origin of carcinogenesis. And then, of course, the most definitive one, but also reserved for the highest population, which is the risk-reducing salpingo oophorectomy, removal of both ovaries and tubes. These are the relative risks I mentioned before. So breastfeeding, nulliparity, infertility, previous pregnancy, OCPs, all those things I discussed. The only thing I didn't mention is the family history, that even with somebody who does not have a genetic mutation, having a relative with ovarian cancer and then compared to 2 or 3 relatives with ovarian cancer significantly increases relative risk of developing it. So options for ovarian cancer risk management, I always think of risk management pretty much the same for every cancer entity. So same as for breast, same as for pancreas, and same as for ovary. So the way I look at it is surveillance, chemo prevention, and again, the most definitive, but the one reserved for really the population that's highest risk, is prophylactic surgery. So here's the trouble. The trouble with I will start with the hardest. The trouble with surveillance in ovarian cancer is because, unfortunately, we do not have good modalities to detect these cancers early. And it's due for many different issues. I'm not going to bore you with the challenges of low PPV, and that you need 10% PPV in order to achieve this 10% PPV. Screening of general population must have a very high specificity, which is almost impossible with this test. So all our markers, unfortunately, have low specificity and also suboptimal sensitivity, having to do with a great deal with low prevalence in our population. That is why the tumor markers that we use for this are limited. You know, CA125 is the one you probably hear the most about, the antigen expressed by fetal amniotic and coelomic epithelium. It's very complicated. It's super, has multiple false positives, multiple false negatives, many different entities like benign GYN disease or GI disease increased, elevated significantly without malignancy, other malignancies elevated. And unfortunately, in early stage, like stage 1 disease, great majority, a percentage of CA125 is within normal limits. And there's multiple different biomarkers that we're looking at. There's different ones. Some are actually good for specific subtypes of cancers. Others are not. And there's a lot of companies right now, and there's a lot of research that's being done in the industry about trying to come up with different biomarkers to try to improve early detection and sensitivity and specificity of the disease. The other limitations, the ultrasounds. Ultrasound right now is a very good entity. It's something that we really use, and it's really quite good. But again, just because of how the ovarian cancer is found and how frequently it's in the fallopian tubes and frequently it's primary peritoneal and not even the ovaries, the ultrasounds, again, sadly, frequently miss early disease, miss stage 1 and stage 2. The OCPs is what I talked about before, and this is the data that we have that shows great risk reduction in women who use birth control pills, especially over cumulative many years. And then the most definitive one would be risk reduction with prophylactic. You know, I don't actually ever use the word prophylactic. I use the word risk reducing oophorectomy in avoidance of ovarian cancer. This is some of the older literature from our institution, from Dr. Peter Schwartz from here, who published in those days in '94 that if all women had their ovaries removed at age 50, if they were having benign hysterectomy, then 12% of women might avoid developing ovarian cancer. You know, in that days, in '94 and probably 10 years ago, we kind of used to do it routinely. We used to take out ovaries routinely in this population of this age women. But now most studies are available, and there's some good studies that show that there's possibly and probably benefit to the ovaries all the way to age 65. So now we are not as quick to take out ovaries in age 50 or so forth, because we now have to balance the risks and benefits. And this is, again, why it's so important to understand who is at risk, who has a higher risk. So for those women, you certainly would want to remove their ovaries if you could. And then the prophylactic sublingual oophorectomy in BRCA carriers. These are the women, of course, who are the highest risk for this disease. And multiple studies have been done. This is just one of them that showed that it significantly decreased risk of ovarian cancer. And in this study, these women, even after risk reducing oophorectomy, had a 1.3% peritoneal cancer. That number is a little bit lower now. We're doing the surgeries a little bit more aggressively, a little bit more radically. We take out a little bit more. But, you know, I always counsel women that they probably have 1% chance of still developing peritoneal cancer even after the oophorectomy, but certainly compared to, you know, 6% in this population. It's also very important to note that when the women remove their ovaries before menopause, it also reduces their risk of breast cancer by 50%. And it's also important to note that for these women, these previvors who are young when we remove their ovaries, not only is it acceptable or okay to put them on hormones once you remove the ovaries, it is actually proven and studied. And not only is it imperative for their heart and their lung and their bones and their mood and their symptoms and their cognition, but there's been studies that talked about safety in the breast cancer population, that because women still have that 50% reduction of the breast cancer just from the oophorectomy, that even the women who were put on a very big dose in the study of hormones post-BSO, they did not have an increased risk of breast cancer up to 5 and 7 years. So that is actually a very important point to know, because that sometimes is something that's misconstrued in the patient population, that they worry they cannot have hormones, and that's not at all the case. So in conclusion, ovarian cancer continues to be very challenging. Ovarian cancer continues to be very challenging because we are failing to diagnose it early. We are, and again, not at the lack of trying, not because we're not aware of it, it's more because we are so limited by the entities that we have for early detection between the ultrasounds and the biomarkers. And because of that, it is so important to understand who are the women at risk so that their genetic mutations can be checked. And if they're truly at increased risk, we can offer them surgical risk reduction. Nowadays, we're doing a lot of risk reduction in younger women with just removing their fallopian tubes to support this theory that I mentioned to you before, that this cancer is coming from the fallopian tubes only. And there's a big trial that's going on right now, just looking at the risk reduction from fallopian tubes alone. But the key, again, is to understand who is at risk and what can be done for this risk reduction. And similar to Dr. Farrell, I similarly have a practice where we have something called Discovery to Cure special practice, where we take care of women at higher risk, both with chemo prevention and surveillance, and then at most extreme times of high risk surgical prevention. Thank you so much for your attention.
Great. Thank you so much to all of our speakers tonight. There are a few questions in the chat, or in the Q&A, but if anyone else has questions, feel free to type them in. Dr. Farrell, there was a question in there for you, and I'll sort of paraphrase, but if a patient has a mutation that's associated with an increased risk for pancreatic cancer, should they automatically be referred to you, or is family history a factor in consideration of referral?
So we do follow the guidelines that are out there that are constantly being kind of revised and reviewed, but essentially it boils down to, for most of the mutations that are out there, they do require a family history. And the exceptions are P16 and Peutz-Jeghers. There have been some discussions about opening it up so that we would end up surveying individuals with just those high-risk germline mutations we talked about, so BRCA2, PALB2, and ATM. That isn't standard of care or follows any particular guidelines at this point in time. So I would say that, I think you have to realize there are some germline mutations that on their own are enough to justify surveillance, but other ones require the family history. Having said all of that, there are times when we talk to patients who have incomplete family histories, or they're still waiting for more information. So for those sorts of individuals, I just tell them to come into the clinic. We can talk, we can tease out other issues of pancreatic disease in the family and kind of at least reassure them and give them answers to specific concerns they have about pancreatic disease. But the short answer is knowing which germline mutations require the family history is important.
Great, thank you. And then Dr. Lynch, there was some conversation, I think, in the Q&A about whether or not to routinely include breast ultrasounds, or whether or not that should really only be reserved for women with high risk or dense tissue. Would you like to comment on that?
Sure. Am I muted? No, good.
Nope, you're fine.
So supplemental screening is meant for women who have dense breasts where traditional mammography is not as sensitive. Supplemental screening can be with whole breast ultrasound or with breast MRI. Connecticut is unique in the country that the first dense breast legislation was passed in Connecticut, and immediately Connecticut radiologists jumped on using whole breast ultrasound for supplemental screening for those patients. And so there's a very deep clinical experience here with supplemental screening with whole breast ultrasound. Other parts of the country have moved more towards using breast MRI, which is a much more costly and much less specific modality because they just don't have the clinical experience that you have in Connecticut. And so whole breast ultrasound should only be used as a screening modality for women who have dense breast tissue or who are at increased risk for breast cancer.
Great, thank you so much. It doesn't look like we've received any more questions, so I think it will end for the night since it's late. Thank you all again for speaking with us tonight.
Thank you.
Thanks, Claire. Thank you all.
Thank you.